is 8:30 and the Senate Public Health and Welfare Committee is called to order. My intentions were to have the confirmation hearing vote, but for those of you that can count, we are one short of a quorum, so we probably won't do that first now. So since we do not have a quorum yet, we can go ahead and do the hearing. So, Madam Secretary, if you don't mind bearing with us for a little while through a hearing, we'll go ahead and have a hearing. But I don't also want to take a vote with 5 people. So we are going to go ahead and open up the hearing on Senate Bill 155, expanding newborn screening services. With the Revisor's Office, Jenna Moyer will give us a bill overview.
Thank you, Mr. Chair. Good morning. Jenna Moyer, Revisor Statutes Office. This is Senate Bill 155, and it relates to the newborn screening, or to just changing the way that newborn screening is done in the state. The first change will be to add a new section that just gives the statutes the name of the act, which will be the Newborn Screening Act. This is a program that already exists for specific diseases that are mentioned within this section 2, which I can't pronounce all of them, but some of the ones I'll be striking will be congenital hypothyroidism, galactosemia, phenylketonuria, and other genetic diseases. And that's listed several times in the statute. That will be changed to conditions included by the Secretary under subsection I. And if you go to subsection I, it states that the Secretary of Health and Environment would adopt rules and regulation to treat for these, or excuse me, to adopt rules and regulations to test newborns for the conditions. And the new language is the Secretary shall determine the conditions to be included in the newborn screening test, including but not limited to conditions listed in the recommended uniform screening panel recommended by the United States Secretary of Health and Human Services. So it would change the newborn screening test to from those 4 or 5 to those that are recommended by the Secretary of Health and Human Services of the United States. And it would also, in subsection L, change the amount that is that would be allowed to be expended in 1 year from $2,500,000 to $5 million in one fiscal year. And then the changes in section 3 and 4 would just be conforming amendments to referencing that subsection I, the change of those, adoption of those conditions. And I'll be happy to answer any questions.
Jenna, thank you for the bill explanation. Just a quick question, maybe a clarification. Currently, this is being done through a budget proviso annually, correct? So all we would be doing is codifying it in statute?
I mean, the newborn screening is already in statute. Is that what you're talking about?
No, about the additions that we're changing, that we're amending on the newborn screening, the funding and everything for the...
Okay, specific to the funding, I believe that, yeah, it is funded on a year-by-year basis, and then this would put that, the amount shall not exceed $5 million in one fiscal year.
Okay. All right, thank you.
Yes, and the fund already exists in statute. It's not changing any of that. The only change in that subsection L is the dollar amount.
Committee, questions? Okay, seeing none, we will go straight into proponent testimony. We have 6 proponents testifying today, no neutral, no opponents. If you're giving oral testimony, we would ask that you keep your testimony to under 5 minutes. That way everybody has a chance to give their testimony and we have a chance to give questions afterwards, and we will hold questions until all proponents have had an opportunity to speak. Committee, our first proponent is Drew Duncan, Screening and Surveillance Section Director for KDHE. Drew, welcome to the committee.
Thank you. Chairman Hildebrand, members of the committee, thank you for the opportunity to provide testimony in support of Senate Bill 155. As mentioned, my name is Drew Duncan. I'm the Screening and Surveillance Section Director, which oversees newborn screening programs. Senate Bill 155 would rename KSA 65180 the Newborn Screening Act, update outdated terminology, and increase funding capitations placed on the program's sole funding source, the Medical Assistance Fee Fund. For the purpose of today's testimony, I'd like to focus on increasing funding capitations to ensure resources are available to conduct a quality, effective, and efficient newborn screening program. Kansas newborn screening is a mandated public health program established since 1965 to protect the health and welfare of newborns with treatable disorders. Kansas statutes require newborn screening be provided at no cost to families. Kansas is one of only 3 states that provides this service free of cost. The cost of newborn screening varies across the United States and is noted as high as $203 per specimen in some states. In 2021, Kansas newborn screening program screened more than 34,000 infants. In 2012, KSA 65180 was amended, establishing the newborn screening fee fund. In 2017, the statute was further amended to cap the funding at $2.5 million. The funding capitation was based on prior year expenditures that were not reflective of an expanded or fully staffed program. In fiscal year 2021, the $5 million budget proviso supported $3.4 million in program expenditures. Kansas aims to screen for all treatable conditions listed on the U.S. Department of Health and Human Services Recommended Uniform Screening Panel, the RUSP. The RUSP includes 35 core conditions and many more conditions on the secondary panel. Kansas currently screens for 34 of the 35 recommended core conditions, with planning to add the 35th condition underway. Over the last 5 years, Kansas has added 5 conditions, 2 of which were only made possible due to financial assistance and support through non-renewable federal grants. The implementation of an advanced universal screening program provides newborns with genetic or metabolic conditions, hearing loss, and critical heart defects the best chance at healthy development. With the expansion of 5 conditions over the past 5 years and the recommendation for Kansas to remain up to date with the uniform screening panel, the program will be underfunded and unable to meet growing needs. Identified needs include long-term follow-up activities, consultation with medical providers, data system enhancements, additional laboratory testing equipment, increased cost of testing supplies, and a courier service to assure more timely transport and receipt of specimens to the state laboratory. It is important to note that Senate Bill 155 does not allocate $5 million to the program annually. Rather, the proposed change to the statute increases the capitation placed on the funds to support growth, sustainability, and flexibility to meet families' needs. I stand for questions, but I think we'll take those at the end.
Carrie, thank you. Yes,
Thank you.
or Drew, I'm sorry. I got ahead of myself. I was looking at the next proponent. So, Drew, I do apologize. Committee, as previously stated, our next proponent is Carrie Padding, Executive Director of the Treehouse.
Good morning. My name is Carrie Padding, and I'm here today to ask you to support Senate Bill 155 because all babies born in the great state of Kansas deserve a healthy start. Newborn screening is truly one of the 20th century's great public health success stories. Newborn screening saves lives and can drastically change the trajectory of life for babies and families. An effective and efficient newborn screening program is important to me because I became a mom for the first time on a warm November day in 2010. A quick and simple test, approximately 24 hours after Gavin was born, the newborn screen consisting of a small heel stick and a blood spot test would make a big difference for us in the weeks and months to come. A few days after we arrived home from the hospital, we received a call from our pediatrician's office asking us to bring Gavin back in because one of his tests had come back abnormal. We were scared and a bit sleep deprived, but of course we complied and the blood spot test was redone. A few days later, we received the call from our pediatrician confirming the abnormal screen for cystic fibrosis. We were shocked, devastated, scared, and had so many questions. What does this mean for Gavin? What do we do next? We were quickly set up with an appointment with the CF clinic in Wichita to have Gavin undergo a sweat chloride test, which ultimately confirmed the diagnosis of CF. After the first care center visit, Gavin began a daily regimen of enzymes, inhalers, nebulizers, and CPT, chest physical therapy, a daily regimen he continues today. I couldn't believe my 3-week-old baby was eating applesauce off of a spoon and taking enzymes with every meal. He wasn't even holding his head up yet. It took many months to reflect back on our birth and diagnosis story, to realize how truly lucky we were that Gavin's first few weeks of life set the course for the best possible health outcome, and it all started because of the newborn screening. I have several other CF mom friends who have older children that were not screened in Kansas or were not screened for CF initially, whose babies really struggled with their weight, their health, and endured numerous medical appointments and hospitalizations before the real cause of their failure to thrive was finally identified as CF. It caused significant financial strain for families, as well as taking a toll on their emotional, mental, and physical health. Gavin's story is a personal success story and a public health success story. Gavin is growing, thriving, and healthy because of an early diagnosis and treatment. And it all began with a few drops of blood and a hearing test to set my baby on a healthy path. In my professional life, I continue to advocate for a robust newborn screening program as the executive director of the Treehouse in Wichita, Kansas. At the Treehouse, we serve hundreds of moms and new babies every year through sharing God's love, basic necessities, education, and genuine personal care. And I'm so thankful to the newborn screen and the early detection of Gavin's CF because I believe he continues to grow today because preventative treatments were started prior to symptoms. Senate Bill 155 allows for all newborn Kansans to continue having the advantage of early diagnosis of metabolic and genetic diseases, which greatly benefit from early treatments and interventions. Like Drew said, each year approximately 35 Kansas newborns are provided initial screening, and about 2,000 will require repeat screenings to complete the process. Please consider increasing the capitation to expand this life-saving and life-changing program to continue to meet the needs of the many families served through the newborn screening program. Thank you so much. I'll take any questions.
Carrie, thank you. We will hold until all proponents have testified. Committee, our next proponent testimony is from Adrian Olechnik, Vice President of KAC. And Adrian, if I butchered your last name, I do apologize.
I'm pretty used to it now. You ignore the J. It's silent consonants. Good morning, Chairman Hildebrand and members of the committee. I'm Adrienne Olnick. I'm the Vice President, Kansas Action for Children, and I'm here today to share our support for Senate Bill 155. The current statutory cap for the newborn screening program does need to be addressed. The $2.5 million cap is now insufficient to meet the needs of the program. In the past several years, this cap has been overridden by a budget proviso, which has extended the cap temporarily to that $5 million. And as you've heard, they've already taken advantage of that increase through actual expenses. This is the core reason, though, why I'm here about Senate Bill 155, to make sure that this new cap can be functional in statute rather than through temporary measures. Kansas, as you've already heard, currently screens for 34 of the 35 recommended issues, and extending the cap would allow our screening program to be responsive to the future, to new diagnostic and treatment options. The value of early diagnosis and treatment for an infant is significant, as you've previously heard. But newborn screening programs are the most time-sensitive programs that you'll fund in your budget. The program not only gives peace of mind to parents when they have a new baby, but helps them realize their wishes. I mean, how many times do we hear that we just want the baby to be healthy when they are born? And that's our mission at KAC as well, for Kansas to be a state where children are happy and healthy. So your support of Senate Bill 155 would be another small but important step in making those aspirations a reality and helping the babies born in Kansas get off to a great start. And we wouldn't have to ask for it every year either, too. So making it permanent would be wonderful. So thanks for your time, and I'll stand for questions at the end.
Thank you, Adrian. Committee, our next proponent is Kirsten Finn, a private citizen. Kirsten, welcome to the committee.
Thank you. Good morning. My name is Kirsten Finn, and I thank you for allowing me the opportunity to address you today as a proponent for the passage of Senate Bill 155, proposing to increase funding capitation for the Kansas Newborn Screening Program. I'm originally Canadian, but now a proud resident of Overland Park, Kansas. I'm currently a member of the Newborn Screening Advisory Council and serve on the subcommittee for the initiative to add XALD. I also volunteer with organizations such as ALD Alliance, ALD Connect, and serve on the board of directors of X Out ALD to raise funds for research improving the treatments for this condition. I come before you today as the mother of a 5-year-old who is diagnosed by chance with adrenoleukodystrophy, or ALD. It is thought ALD affects 1 in roughly 17,000 births and is a relentless and progressive neurodegenerative illness that, if left untreated, can result in death in 6 months to 2 years. ALD destroys the myelin in the brain, and boys lose their ability to see, hear, walk, communicate until they fall into a vegetative state and die. Men who develop the adult onset form are often misdiagnosed with psychiatric conditions and become homeless or incarcerated for actions simply beyond their control. Women with ALD are often misdiagnosed with conditions like MS. All ALD boys develop adrenal insufficiency at some point, and this alone can be fatal if left untreated. The only known treatment known to halt the progression of the disease is blood and marrow transplantation, and the window for treatment is exceedingly narrow. Newborn screening for conditions like ALD is essential and life-saving. My son was diagnosed by chance shortly after his 4th birthday at the beginning of the pandemic. We were in Canada at the time and could not get a timely MRI. There were no ALD specialists. And by the time we had the MRI, learned he had developed the most severe and fatal form of the disease. No one in Canada could tell us if we were in the window for transplant and could not give us a timeline for treatment. We were denied out-of-country coverage and were forced to liquidate our retirement savings in order to bring our son to the University of Minnesota Leukodystrophy Center, where our son received a life-saving bone marrow transplant in August of 2020. Our son has some fine motor delays, cerebral visual impairment, and auditory processing issues, but these conditions are treatable, and he's a very happy kindergarten boy. We're forever indebted to Dr. Troy Lund at the University of Minnesota for saving our son's life. The reason I'm so passionate about speaking to you today is that we're the lucky ones. I shudder to think of how close we came to losing our son, or how he might have been condemned to a life of severe and debilitating disability had a transplant been performed too late. If we had the benefit of newborn screening, we would have been able to monitor our son from birth, and he could have accessed treatment earlier, thus limiting disabilities he now faces. Newborn screening has a far-reaching impact for every positive screen. Siblings, cousins, and adults alike are identified with every screen and have the ability to receive life-saving and appropriate treatment. They also have the ability to have the benefit of this knowledge for future family planning. The knowledge gained with newborn screening quite simply saves lives and prevents the devastation faced by family who come to a later diagnosis. I have met so many families in my volunteer work from across the US and around the world who receive transplants too late. Their children have severe disabilities and cannot see, hear, must be tube-fed, and have to be trached. These children will never improve and will never return to their former level of function. I've also met many families who have devastatingly come to a diagnosis when they are far too late for transplant. These families must then take their child home and watch them slowly lose every functional ability they have before they fall into a vegetative state and die. What I have seen with ALD is true for so many other diseases on the newborn screen panel. These rare diseases often mimic other conditions, and the potential for misdiagnosis is exponential. Usually, unless rarely diagnosed by chance like our son, most children are diagnosed too late for any kind of meaningful intervention. There have been significant advancements made in blood and marrow transplantation and innovative gene therapies for many of these conditions, but these interventions can only be performed with early diagnosis. Receiving a fatal diagnosis for your child is traumatic. My heart breaks for the families who've lost children and who must every day live with the fact, knowing that had screening been in place, they could have saved their child. Families who do receive screening also face trauma as they learn to navigate complex medical conditions, and they need immense support as day after day they must face the unknown and possibility of having to undergo a life-saving procedure. The lack of newborn screening for treatable conditions is quite simply death by geography. I'm very passionate about advocating for newborn screening and in doing what I can for all rare disease families, regardless of their diagnosis. A robust and comprehensive screening program is essential to ensure every baby has the right to life and to achieving their best possible outcome. I don't ever want any family to go through what we did or worse. I stand before you today to implore you to pass Senate Bill 155 so that the Kansas Newborn Screening Program can continue to sustainably provide every Kansas child their best chance in life. Thank you.
Kirsten, thank you very much for your testimony. And before we go to our next proponent, we do have Senator Ron Reichman with us, so just wanted to say welcome to our committee, Senator. Our next proponent testimony is Travis and Deanna McMillan, private citizen. Travis and Deanna, welcome to our committee.
Thank you. Committee members, thank you for your time and consideration of this hearing. My name is Travis McMillan. This is my wife, Dina. We know you have or will hear testimony from experts and other private citizens. And by the way, it's you drive a hard bargain. We are neither. We live this life. We are ALD parents.
Our journey began 5.5 years ago, shortly after our son Aaron, who is here with us today, had his 5-year shots mixed with the flu shot at the same time. After 2 days, he'd always had a minor reaction to vaccines, and so at first it wasn't anything, and I apologize. She got me crying, so. It wasn't anything ever this big, but he was fighting a fever. He was lethargic. He wasn't eating, which was not our boy. We had taken him back to do blood work to make sure something else wasn't going on, and his blood sugar was extremely low, and so they sent us to the ER. While we were in the hospital, Aaron was diagnosed with adrenal insufficiency. The endocrinologist on call actually diagnosed him by his color first, as he had an Addisonian tan, and then through blood work. He'd always had a beautiful tan. We just thought that that was his skin tone. Kind of jealous, to be honest, before we knew. We later found out that we had just experienced his first adrenal crisis. We were in the hospital for 4 days as they tried to figure out his steroid dosage before we were sent home. Our endocrinologist drew more blood to attempt to figure out why he had adrenal insufficiency. She really thought it was autoimmune, but ran the blood work to be safe. We found out over the phone that Aaron had primary adrenal insufficiency, but it was not autoimmune. So this was where his brain sends messages to his adrenal glands, but his adrenal glands don't respond. We also found out he had adrenoleukodystrophy, or ALD. It's a devastating diagnosis when it's first given to someone. And that was the path we started down. Without proper medical treatment, he could have easily died due to blood sugar crash, low blood pressure, dehydration, or other disease-related complications. Once we had that diagnosis, we started the level 1 worry. How will this affect us? How will this affect him? Will he have a normal childhood or a normal life? Since it wasn't the diagnosis we wanted, it was the one we received, and so we started advocating then for him. We started reading the studies on adrenoleukodystrophy, and these studies are not for the weak of heart, and I don't ever suggest searching for something on the internet once you find out what's going on. Dr. Huerta, our endocrinologist on call that night, connected us with our experts, Dr. Lipashan, our neurologist in Kansas City, Dr. Rizzo, our metabolic geneticist in Omaha, and then Jill, his nutritionist. We were also accepted into the Lorenzo's Oil study. But had we been in a rural county or town, we are from Wichita, Aaron may have died because being in a larger city, we are blessed with more resources.
ALD has no known cure in the United States. There's no cure. There's a bone marrow transplant which allows for the stoppage of progression. In Europe, gene therapy is available for boys and men who have symptomatic adrenoleukodystrophy or adrenoleukodystrophy. But if we truly care about children, then this test is critical for them and their families, as early detection means that these treatments can happen as soon as the regression is diagnosed through an MRI. We are lucky that the pediatric endocrinologist diagnosed adrenal insufficiency first, as many families find through regression through ALD, and by then it's too late for treatment. The cost of the screen after a child is born is unnoticeable compared to the cost of the health crisis and diagnostic journeys without screening. The financial burden occurs because of diagnosis, travel to specialists, and treatment. Aaron currently has 2 MRIs per year, blood work on a regular basis, and this is in addition to his regular checkups. His sister will have to have genetic testing for ALD should she choose to have children. Proper care is necessary for a longer life. Early detection of devastating and treatable conditions like ALD leads to more information, which should contribute to better care and being placed with the correct experts for the child. Having seen our specialists with Aaron, we know this to be true for us. At this time, Aaron is asymptomatic, and we haven't had to prepare for a bone marrow transplant with him. We will hope that you have considered our testimony and will consider passing this bill so that the Kansas newborn screening can provide additional conditions like ALD to the screening panel and continue to meet the needs of Kansas families. We appreciate that you have taken time to listen to us, and thank you again for your time.
Travis, Indiana, and Aaron, thank you for showing up and testifying. Committee, our next and final proponent oral testimony is by Troy and Emily Reimer. They are private citizens. Welcome to the committee.
Good morning, committee. Thank you for hearing my testimony. I am only Troy. I'm not 2 people. Just to clear that up. You've heard a couple stories already about ALD, and I'm here to add another one. I can't speak to the intricacies of this bill, but I do advocate for the passage of it, and also the addition of ALD to the screening panel as recommended, as the RUSP has recommended. I'll just tell my story and our story, our family story. We thought it was just the flu. Kids get sick sometimes, right? But our precious 7-year-old son just wasn't getting better. He became listless, so we rushed him to the ER. The doctor did some tests that showed that he was having an adrenal crisis. And then I remember the fear that I had when the doctor said, "I'm sorry, but we can't care for your son here." So he was rushed to Children's Mercy. How is this possible? It's just the flu, right? But it wasn't. Even then, we didn't know. We nearly lost our son that night because we didn't know why. Even at Children's Mercy, he was stabilized, thank goodness, over the next few days. And they ran several tests, and similar to Aaron's journey, he had a wonderful tan. We thought it was just a tan. It was not. Initially, they thought it might have been, they did diagnose him with adrenal insufficiency, and they thought it might be Addison's. We wish it was Addison's. They ran other tests, and it came back that he had adrenal leukodystrophy, which, as Dina mentioned, it's not for the faint of heart to look up on the internet. I'd never heard of it. It's a rare disease, so it couldn't be that, right? But it was. Our lives were turned upside down when we got the news. We were devastated, but at least we knew. I'm here to advocate for including ALD in the newborn screening regimen here in Kansas. Our family was taken by surprise, and we nearly lost our second-grade son because we didn't know. The diagnosis will be overwhelming no matter when you hear it. But it's better to find out early when it can be monitored. Including it in screening will give new parents a chance to plan and for the best care to be given. Currently, 27 states have already added adrenal leukodystrophy to their newborn screening, according to aldnewbornscreening.org. Also, according to that website, there have been 260 boys found that had this condition that they can monitor now. New York was the first in 2013, thanks to the tireless efforts of Alyssa Seeger to pass Aiden's Law, in memory of her son who died without early diagnosis. In our own region, Nebraska, Missouri, Oklahoma, and Texas have added it since 2018. We should too. Newborn screening is important. Newborn screening for ALD is important because it is genetically acquired disorder that occurs in approximately 1 in 21,000 boys born each year. Unless there's a known family history for a condition, it will go undetected. When symptoms do occur, usually between the ages of 4 and 10, it's often too late for effective treatment. With newborn screening, boys diagnosed with ALD can be monitored for cerebral progression and receive treatment to give them a better chance at a healthy life. Our son nearly died because we didn't have an early diagnosis. We want better for other families. Thank you for your time.
Troy, thank you for your testimony. Committee, that does conclude our proponent testimony today. I would draw your attention, we do have 7 written-only proponent testimony. At this time, we will open up for questions. Any questions from the committee? Senator Thompson.
Thank you, Mr. Chair. I guess it would be for Drew Duncan. And do we currently, screen all kids or?
Every baby born in Kansas receives a newborn screen.
So that's about 35,000 a year approximately.
Yeah, it's gone down slightly over the past
Yeah.
couple of years. Yeah.
Just wonder, what's the cost of a screening? Just curious.
I would have to call on our director at the lab, Dr. Phil Adam, to speak to that. I believe best estimates we had a couple years ago were about $8 per screen. Oh, okay.
Okay, that makes more sense math-wise, because if you take 5 million divided by 35,000, you come up with about $142, so, $143. So I was just kind of curious if that was going to be a sufficient number to cover, so I think that answers it. Thank you, Drew. Thank you, Mr. Chair.
Senator Gossett.
Thank you, Mr. Chair. And Drew, could you come back up to the mic? Thank you. Sorry about that. As I'm reading through the bill, and when I read it the first time, I don't think I caught this, but it's more than just screening in this bill, correct?
It's updating the language, but also it goes to administrative costs, staffing, more than just the specific screen that's conducted itself. It really supports the network around each new condition. We have specialists that have been at our door for the last several years and are requesting compensation because of the consultation services. Like mentioned, some of these disorders are very rare, so the idea that all of the PCPs are aware of what the various rare conditions are, they're relying on our specialists quite a bit, and we've been unable to have substantive talks around those consultation contracts because of the lack of funding that's available to enter into a long-term agreement.
And so we all, of course, our heart goes out to all of these proponents, and, you know, being a mother of 4 and a grandmother of 4 and 1 due this month, we're all concerned, of course, about pre-screening and making sure that as soon as possible we can identify any problems that a child is having. But what I'm reading in the bill is about food that's delivered to the home, products that are delivered to the home.
And there is a part where PKU formula is a part of that, and that we don't want any increase in funding to take away from that. It is separate from our newborn screening fund. The formula is provided.
I think that's all the questions. Thank you, Mr. Chair.
Senator Petty.
Thank you, Mr. Chairman. This is a question for Carrie. And Carrie, thank you so much for being here to testify. You mentioned that through the heel prick that your child had, or your baby had at birth, that you were able to diagnose cystic fibrosis, or the hospital was able to diagnose cystic fibrosis. And sometimes we get into conversations about what kind of savings come about because of the early diagnosis. And so you mentioned about how your child is thriving. So I don't know if you actually have a figure, but from your perspective, do you see things that you haven't had to go through, maybe through school or through education-wise, that might have been had occurred if this cystic fibrosis hadn't been identified earlier?
Absolutely, and I have several, friends who are around my age who live with cystic fibrosis, other moms that I've talked to and gotten peer support from who have older kids whose kids had to be in the hospital. They got infections really frequently in their lungs. They've had ports. They had to have IV antibiotics very often. We've never had to do that. We've never been in the hospital for infection. We've only ever been on oral antibiotics because cystic fibrosis, because he has the most common mutation of CF, he's been able to start on Trikafta, which is a new triple combination drug that's specific to his mutation, and he is doing incredible. It's not a cure per se, but it does change kind of who he is, and he is showing that he can reduce his burden of treatment. We are reducing enzymes. We are reducing the number of pills, 15 to 20 per day. We're going to be going down. We were just at CF clinic yesterday, and he's doing really, really well. So we have not had to struggle because we started CPT nebulizers. We still do that. We do those twice a day. He wears a vest for 30 minutes a day that shakes the mucus from his lungs, and he takes these life-saving pills. If we didn't have insurance, Trikafta alone costs $311,000 per year. We wouldn't be able to afford that. But thank goodness for copay assistance and getting him started early. He's on a really good trajectory. The adults that are on this new drug, one of my good friends who's in her early 40s has gone back to work. She was on disability for 10 years, but Trikafta has given her a new lease on life and is now employed back in child welfare. So even the physicians at Wichita yesterday, we were talking that the residents aren't able to see what a normal CF patient looks like in the hospital anymore because of these drugs. So it's made a life change, big life change. Thank you.
Thank you.
Senator Baumgartner.
Thank you, Mr. Chair, and thank you so much for the parents in particular that testified. It gives us a real story in addition to the text of the bill. My question is for Drew. Welcome back to the mic, Drew.
Thank you.
You did mention about the specialist consultation, so I'm a little curious. Are we needing to refer to consultants that are outside of the state, or do we have adequate consultants within the state?
That's, I guess, a difficult question to answer. Around the conditions that we currently screen for, we just know that there's a strain on their capacity due to not being able to bill for hours. And when a physician receives an abnormal screen, a call out, and they call Children's Mercy, the specialists take the time to respond to them, even though they're not able to bill for them. And so, I couldn't speak to XALD, but we do know that it's important to and make sure that there's a infrastructure in place to bring on a new condition. We could, the lab could technically screen for a secondary condition just with what we have, but we know that it would be irresponsible to bring that on without ensuring that there's specialists in place, that we have the education and the information to provide to families in a timely manner prior to bringing those on.
I appreciate hearing that, because I think that's an element that's not really been expressed with an early diagnosis, with that newborn testing. And again, it's newborn testing. That early diagnosis also then allows parents to start finding that network of care providers that they would need in the future as well. And so, thank you so much.
Senator Gossage.
Sorry, Darren.
Drew.
Thank you. Drew, not Darren. I don't even
You're
know where I
fine.
got
No worries. I'll respond to whatever.
Drew, apparently you're a man of many names.
There you go, yes.
So we just can't get your name correct. And you would think
A
a
few
name
more
like
tries will have it
Drew
down, I
would be.
think.
No wonder everybody chuckled when I said that. Okay. Again, a couple of questions, and I know that this is in current law. It's not part of the deletions or additions for this bill. So I'm trying to understand, as a health insurance agent, I know that it's covered under a health insurance policy to have a newborn screening. This is why I'm trying to understand if the state is paying for this. Online, on page 2 on line 19, it talks about income, or if it's covered by a third party, the state doesn't pay for it. Can you tell me how this has worked out
I believe that,
logistically?
and I don't have it in front of me, but I think that's relating to the formula and those types of things, which again is separate from our newborn screening that's provided through our special healthcare needs program. But can you rephrase the question? I'm sorry.
No, that's okay. It mentions if you're below the poverty level, or if you're
Yes.
Medicaid eligible, it's covered there.
Okay, yeah, so that is in relation to
100%.
the formula. There is a decision schema for that and income schema, but screening itself, the newborn screening, the blood spot card, the testing at the laboratory is all free. The follow-up services, calling out those abnormal results, connecting with physicians, specialists, following up with families that initially with a letter, and then following up if we haven't closed the loop with a diagnostic result, and then other disorders where there's a follow-up at 9 and 12 months. All of that's encapsulated in that $5 million budget.
So when it says section 2, which is there's hereby established an advanced universal newborn screening, and then we've got subsection A, B, C, D, and E, and then E is where it goes into the income related.
Income is totally related to the formula and I apologize, I can't speak well enough to it because it's not in my wheelhouse, but it is separate from the screen itself. So our special health care needs program manager could probably speak more eloquently to that, but there are income guidelines for those supports, but unrelated to the newborn screening itself.
Final question, if the state is providing, or the taxpayers are providing a newborn screening, but yet the insurance coverage covers a newborn screening, are we not just saving the insurance companies money, or how are we?
Honestly,
Is there any reimbursement for that back to the state?
there's not that I know of, and I'm not adept enough to speak on how that works, but
Okay.
yeah.
Thank you, Drew.
Senator Erickson.
Thank you, Mr. Chair. Just a comment before my question. In 1990, I was one of those parents who got the call. I remember the panic and the fear with our firstborn son. So it really touched my heart today. So thank you for the parents who came today. Fortunately for us, the follow-up test, he was okay. But I know that feeling, so my heart goes out to you. Okay, my question is probably for Jenna. Jenna, do we know the total amount in that medical assistance fee fund?
Jenna Moyer, Revisor Statutes Office, I don't know it off the top of my head, but I can look and see the amount appropriated. That the balance of that fund is not information that I have. That might be something research could track down for us, though.
Okay, I'd appreciate knowing the total amount in that fund. It seems to me like going from 2.5 to 5 million, depending on the total amount that fee fund brings in, we might be able to make some provisions there. And by the way, my son's name is Andrew Drew, so I will not forget your name. Thank you, Mr. Chair.
Senator Petty.
Thank you, Mr. Chairman. This would go back to Drew. Drew, just this is kind of a follow-up to the questions from Senator Gossett. So some of the things that she was addressing, they don't change in this bill at all, do they?
No.
No, they're already in current law.
Right.
And concerning the fee fund, I want to make sure I understand this correctly. So in this bill, we're asking, the request is to increase from 34 to 35 potential areas that would, the child, the prick that was done when they're born would be tested for.
So this funding would allow those implementation activities to continue. We've already begun, and due to some staffing issues and COVID at the lab and turnover in staff there, we've had to kind of put a pause from the lab side as far as the implementation of XALD. However, we're continuing those on the follow-up side to ensure that when we are able to pick that back up with instrumentation testing and things like that, that we're able to do that as efficiently as possible.
Thank you. And the up to $5 million that is the request in this fund, that would help to assure that every child that's born in Kansas would be able to, there would be the funding available there to do the testing.
Yes, and it allows us to, and again, my lab partners could speak better to it, but there are a number of conditions that will be added to the RUSP in coming years because of new treatments that are being found and diagnostic testing and things like that. So this funding allows us to really, I guess, meet the definition of robust and comprehensive, where we're noticing that we would like to enhance our information to families around specific conditions, where we're able to right now. Our materials and information are more generalized to the newborn screening process itself, and in general, the abnormal process when we receive results and following up for diagnostic testing. And so we would like to expand and expand in a sense so that we can build out our resources and information that goes to families.
And lastly, Mr. Chairman, I've kind of had this presentation before, not exactly from you, but concerning the newborn screening. I was under the impression that without the addition of up to 5 million, that it wouldn't allow for this type of expansion that you're talking about.
That's essentially correct. We would have to look at a cost that would go back to either the facilities or families. We won't stop screening, but we know that the costs for instrumentation, testing are not fixed, and they increase, with inflation. And so while we won't stop screening for what we do, and I can attest that we're as effective and efficient as we can be with the resources we have, it does limit our ability to bring on new conditions.
I would say any of us that have had to have anything, gone to the hospital for anything and had looked at the bill and saw what testing for anything costs, that we'd have to agree with that. Thank you.
Committee, I don't see any further questions. So without any further questions, we will close the hearing on Senate Bill 155. Thank you to all the conferees for coming and giving us your testimony. Committee, we now need to turn our attention to the confirmation of Secretary for KDHE, Madam Secretary Stanek. So just as a refresher, we have three options today to pass out favorably, recommending or passing out recommendation to be confirmed by the full Senate, not to be confirmed by the full Senate, or without any recommendations. So with that, what is the will of the committee? Senator Petty.
Mr. Chairman, I make a recommendation that we pass out the recommendation to the full Senate of Secretary Stanek favorably.
We have a motion on the floor by Senator Petty to pass out the recommendation favorably to the full Senate for Secretary Stanek. Do we have a second? We have a second by Senator O'Shea. Is there any discussion on this motion before we take it to a vote? Senator Thompson.
Thank you, Mr. Chair. On paper, Ms. Stanek's resume and experience is solid. There's no doubt about that. But so was Dr. Norman's. And over the last year, we discovered that policy decisions make a huge impact on people's lives. It can close businesses, it can close schools, it can even cause death. And under the emergency management statutes, the director of health has enormous power. And we saw the previous director follow CDC guidance pretty much blindly when we had evidence to refute all sorts of that information. There was a great Barrington Declaration. There was studies that we knew prior to this that the viral particles could pass through masks, yet we masked kids for 2 years. We closed up schools. And it's one thing to make those decisions without the benefit of hindsight. But I've had conversations with Ms. Stanek in my office and talked to her here, and I appreciate her candor admitting that CDC would be her ultimate guiding light. And people lost jobs. We remember the KDOL situation. We lost $700 million to fraudulent claims because of closed businesses. The vaccines were rushed to market. $18 million in ads were spent by the state of Kansas to tell people that the ads were safe and effective. I got an email 2 hours ago from a man who said, my 23-year-old son died from the Pfizer COVID vaccine. He didn't smoke, didn't drink, didn't do drugs. He had no underlying conditions except the fear of dying from COVID-19. So he got the shot and he died. There was all sorts of VAERS data that produced this as well. My concern is that we're going to end up with the same situation. Someone who blindly follows institutional health guidance does not consider any other guidance whatsoever. Now, is she qualified to run an agency? Sure. But I have serious concerns about her ability to look outside the institutional health and to make the decisions necessary to save lives in Kansas, save jobs in Kansas if she were facing the current, in a similar situation. And to her own admission in testimony yesterday, the pandemic's not over. So what kind of things are we going to see going forward if there's a spike in cases? So with that, I cannot support the recommendation at all. I would, in fact, offer a substitute motion to not to recommend, but that would be the will of the committee. Thank you, Mr. Chair.
We do have a substitute motion on the floor by Senator Thompson to not recommend. That is in order. It would be debatable after we have a second. Do we have a second? Not seeing a second. The substitute motion dies for a lack of a second. We are now back on the original motion of passing out the secretary favorably or with recommendation. Senator Erickson.
Thank you, Mr. Chair, and I agree with Senator Thompson on paper. I think there's no doubt she could run an agency. I agree with Senator Petty on some of her. I guess I'm kind of in the middle. I would like more vetting. I would like to know more. The hearing yesterday brought probably more questions to mind than answers as it relates to her confirmation. So in listening and weighing that, I would make a substitute motion to pass her out without recommendation. Thank you, Mr. Chair.
We do have another substitute motion by Senator Erickson and a second by Senator Baumgardner to pass out without recommendation. It is an order and it is debatable. So any comments on this motion? Senator O'Shea.
Thank you, Mr. Chair. I guess I have a question, maybe for Senator Thompson, if he's willing. I do not like the way the pandemic was handled. Don't get me wrong. That's why I ran for office. But I'm curious, do we think it's possible to find someone for a position like this in the government that wouldn't follow CDC? Have we seen that in other states? Just curious.
Yes, we have. We've seen a number of other health directors in other states. Florida, for example, I think his name is Lapido. I can't pronounce it correctly. And other states who didn't follow this sort of guidance, who thought outside the box and didn't lose businesses. To me, when we, and thankfully she did follow a recommendation to pull some of these ads on the vaccines because there are people dying from the vaccines. So I'm very concerned. Do we find somebody like that? I don't know. I personally think we need somebody because we now have the hindsight of the past 2 years and what has happened and what can happen if somebody doesn't look outside those institutional health guidelines and think outside the box. I mean, I'm a meteorologist. I was able to find volumes of data that I was able to understand, research that I was able to understand that refuted all of what CDC was doing. And so, and that wasn't even my job. I was just trying to protect my constituents who were losing their businesses and jobs and concerned about access to health care. I have a friend who died of a heart attack in a hospital parking lot because he was waiting on a COVID test to get inside. These are the kind of things that we heard over the course of the last 2 years. And now I just feel very uncomfortable and very unwilling to accept somebody who just accepts blindly the CDC testimony or guidance. They've been all over the board. They finally backed off on mask mandates. They've changed their tune so many times it doesn't make sense. And that's why I say, as my job and my previous job, I didn't follow the American Meteorological Society recommendations. I did my own homework, and I thought outside the box. I did that for 40 years. It's not hard to do if you want to put the work in. And I think that falling back on CDC guidance got us into all sorts of trouble with schools, with counties, with states. This is not, and I hope Ms. Stanek doesn't feel like this is a knock on her. I'm just looking at policy decisions. And I don't want those kind of policy decisions going forward.
Senator Baumgardner.
Thank you, Mr. Chair. I would just like to comment on, we are going through this process with regard to the nomination for this position, but all of us have served on other legislative committees where we have gone through other agency budgets. Most all of them have added for this fiscal year travel, and under the amount that they've requested is the sentence, due to the ending of the pandemic. So while it seemed like a simple question that was posed yesterday, when did the pandemic end? The answer of the serving secretary is that it hasn't ended, yet all of these other agencies have added to this year's funding request travel because the pandemic has ended. That is a concern to me of someone that is the head of this agency, that the information has not been spread to the others. Oh, by the way, in her opinion, the pandemic has not ended. So that is why I do support that recommendation.
Committee, we are running out of time. There is another committee that does meet after us, so there are 2 more comments. If you guys could just please make it brief so we can exit in a timely manner for the next committee. Thank you. Senator Petty.
Thank you. I appreciate the comments of my colleagues here. It's always easy for us to be armchair quarterbacks 2.5 years later. But we have been through a very difficult time, and we do need someone in the position of the Secretary of Department of Health and Environment that looks at the whole picture, and we should not make our decisions based totally on what we think about certain things concerning COVID, because I would disagree with many of the statements that have been made. This is a big department. It's multifaceted, and and we're looking at having someone with a vast background. As we listened to yesterday, if we listen to all of the questions that were asked, and we've looked at, I know we all looked at her application, that she has the skills to help with, one, coordinating those departments. She wants to see them intertwine more. She had multiple questions about working with the communities that throughout our state. Very good questions that were asked by my colleague, Senator O'Shea. So I think that we need to have someone with great abilities in this position, and I think that Mrs. Stanek exhibits those. And so I think we're doing a disservice to our Kansans if we don't pass her, or if we don't recommend her as secretary.
Okay. Committee, we will now take this to a vote. All those in favor of the substitute motion to pass out the without recommendation, say aye. Aye. Those opposed, no. No. The ayes have it. She'll be passed out without recommendation. Secretary Stanek, one of the things that you had told us and you told me personally was you're one that listens and takes what people are saying. I hope that you take this as there is a lot of great concern on this subject, not only with senators and legislators, but also with the people in the state of Kansas. So wish you the best of luck on the vote. So without any further ado, we are adjourned.